comes with the system. Now all you have to do is hit that button,
Yeah.
the monitor's gonna come on with it.
Hey, Mark, quick question. You guys said this is one of the most common units out in practice. Just out of curiosity, what are the main competitors, or what are the other things that are out there?
Well, the two top companies out there are Quantel.
Which is Ellex now, isn't
Well,
it?
now it is,
Okay.
yeah.
Which is new.
It is new. It happened in June.
Oh, okay.
So Quantel and Ellex would be the top two companies out there. And like you said, those two companies merged. And so now there's a duplication of some products. So they'll probably at some point get rid of some of the duplicate products
Okay.
and kind of narrow down the product lines a little bit so they're, or, you know,
Yeah,
there's
there's
a bunch of extra stuff.
redundancy, yeah.
Yeah.
Alexis, what else when we go to put, if we don't see one of these, what are we gonna see?
No, that's what we were saying, is Quantel
Okay,
and LX.
those are the ones, those are the only ones we'll see.
I would say those would be the top ones again. There's another smaller company, called Sonomed that,
Which is what our A-scan is in clinic.
Mhm.
Oh, okay, all right,
Yeah.
so there's not some hot little tiny little A-scan that everybody's gonna spend, nobody wants to buy it because it's $20,000.
no, there are, some little, like, they call them probe on a rope, kinda like soap on a rope in your shower.
Yeah, right.
Kinda like a probe on a rope, but you don't get very good images. It's kind of like,
Micromedical
yeah.
type stuff.
So this is worth my time.
Yeah, so, and then the other thing, you know, not to
Yeah.
jump ahead, but with the A-scan on this machine, you can save movies, you can roll back, and you really get to fine tune your measurements on this, so we'll get to that, but, you know, you can do a lot more with it.
Do you wanna have everybody come up? or
Yeah,
how
I
you
think
wanna
that
do
would be,
Yeah.
that would be better. Now I feel at home. So when you first log into the system, you're just gonna type in the password, which is i3admin. And you'll type it in wrong, like I just did.
I do that all the time.
I do too. I keep clicking the caps lock button. So when you log into the Windows login, the software will open automatically. It just takes a moment. All right, so this is the screen that you'll see when you first log in. All of these scans here are all demo cases. So if you're looking for different examples of pathology, you can scroll through all of those, you can practice, you know, measuring things, and it's really kind of a good resource. Yes?
Not to get too off topic, so what would be like the top 3 pathologies, would you think? Cataracts?
No, I
No?
would say ocular melanoma, retinal detachment, and optic nerve head drusen.
Optic nerve head drusen?
Yep.
Okay, I can imagine that. Melanoma of
The intraocular melanoma,
intraocular melanoma.
Yep.
And,
Choroidal or?
choroidal melanoma, yep.
okay, so on the lining somewhere, on one of the lines, okay.
Yep.
And then what was the other one?
Retinal detachment.
Oh, retinal detachment.
Yep. So basically anything, any type of pathology that is elevated in some sort or has a different reflectivity of other tissues within the eye, you're gonna pick up on ultrasound. If it's something so small, like, you know, even some ERM, CME, you can pick up on ultrasound if you're right in the macula.
ERMs,
But you'll be able to pick a lot up.
ERMs.
Epiretinal membrane,
Oh,
or a macular pucker.
okay.
Okay, so if you want to, say you wanted to click on one of these examples, or if you guys are practicing and you have test names in there, you're just gonna double click. And it will load. And then you're going to click on begin session. I don't know how you guys are gonna input, you know, like how do you put in patient names or anything? Do you do that now, or is it all test?
Well, things are changing with this machine, so we don't want to put in too much patient identifiable information. So we are just going to put in their first name,
Okay,
like the first 3 letters of their last name,
okay,
And then instead of their date of birth, we're gonna have everybody's date of birth be like January 1st of
Okay.
whatever year they're born.
Okay. What about patient ID? 'Cause that's the one that you have to put in. So I don't know
Oh,
if you wanna
do?
use,
Okay, that we didn't go through because I didn't know we have to put in a
Yep.
patient ID.
So can we just make one up?
Yeah, we could just
Just 1, 2,
probably
3, 4, 5?
assign one.
yeah.
How
Yeah.
long should it be? Is there a
Um,
digit limit?
I mean, when you're in a hospital, it's usually like 7 or 8 digits, but you don't have, I mean, you don't
I
have
was
to.
thinking it would be nice to associate it with a G number, but then that's too much identifiable
Yeah.
information, which is not gonna go well with our IT and everybody else. So we're just gonna have to create a number.
I'll
Yeah.
make a list of numbers of your names, how about that?
Ah.
Can I do that with 7, is
Yeah.
that all
I
right?
would say a 4-digit is probably easy enough for us, but
Yep.
enough that, we're not
Where you
gonna
have to know
have
your number, but
almost
keep it.
10,000,
Right.
patients.
Yeah, we could absolutely do a
Okay.
4-digit if we can. Do
And you can
something-
search, you can, there's
Uh-huh.
tons of search parameters, so if you forget what the number is, you can type in the first 3 letters of the name, like you said,
Uh-huh.
and do that. So before I get into going into existing patients, to add a new patient, you're gonna type in, your numbers. So 1, 2, 3, 4 is already in there, so I'm gonna just do, I don't know,
Oh.
Darn it.
you wanted to
2,
take
3,
it
5.
easier.
And then you're going to hit enter, put your number in. Well, actually, I clicked on new, so it's already doing that. So when you're just setting up here, just ignore what I did. Put in the ID and click on enter, and it will prompt you, do you want to create a new patient? Click on yes, and then these fields will open up. And then you can put in your name. And you don't have to put a date of birth in, but you can, as far as IT, I don't know how if you're sending the images somewhere.
We are not, we're not sending it
Okay.
anywhere, it's
Okay.
just gonna be here.
Got it.
But
And then-
date of birth is not a required
No,
field then? Okay.
no.
Okay.
Nope.
alright.
You can even you can write comments in here, if you wanted to, make a note. And then you just click on save. And so that adds it to the database, and then you're ready to go and do your scan. Now, I don't know if you wanna put examiners, physician, I can show you how to put all of that information in and delete it if you need to delete it, because I know that you guys are gonna be, rotating a lot of people through. It's easy as just clicking add examiner and add physician there. And then when you're ready to scan, you're just gonna click on begin session. And this is where you start driving. So this is where the fun starts. On this page, you have your right eye, left eye, and you just toggle between those buttons. And then you have your modalities here. So you've got your B-scan, your UBM, your diagnostic A-scan, and your biometry A-scan. So whatever you want to scan, you just click on that modality. Now keep in mind, if you click on these twice, it's going to change the mode. So you may see this red line, you may see these parameters down at the scale at the bottom of the screen. It's just changing, it's giving you a few different scan options, and I'll go through what those all mean. Same with the UVM as well. Diagnostic A scan, and let me go through the pros. So posterior B scan, you're gonna do everything that's behind the lens. So it's gonna be the front of the eye here, towards the back of the eye. Your UVM is gonna look at everything from your lens forward. Your diagnostic A scan is specifically for tumors, so looking at, people use it for different membranes as well, but it's most commonly used to look at tissue structure, internal structure, and reflectivity. So does it look like a melanoma? Does it look like a metastatic lesion, or does it look like a benign lesion? Or a hemangioma? And of course, you have your biometry, which you can measure your axial length of the eye. You can use these interchangeable, so if you're, in the middle of doing a B scan and you say, I need to look more towards the front of the eye, you can switch right over to your UVM and then go right to your A scan. You don't have to start a new session. So that's the modalities. Under here, this is how you're gonna label your images. Now, out in the field, there's a few different protocols that people use for their B scans and their UVMs. Everywhere you go, you'll be told a different protocol, depending on how that facility does it. the basics are going to be about 5 images. So you're gonna scan through the quadrants, scan through all your quadrants, and then you're gonna do a horizontal axial. And I'm gonna go over all of that with you. And if I'm jumping ahead, or what I'm saying doesn't make sense, just please let me know.
Well, and a lot of this too will make more sense when you're in Dr. Martell's imaging sessions coming up.
Yeah. Does she do ultrasounds?
She will be doing the training here today.
Okay.
Yeah.
But she doesn't, okay, I just wanted to know previously if she had,
I don't know if she did
I can
at
ask
the
her too.
VA
Yeah,
or not,
okay.
but.
Yeah, I'm not sure how much exposure she had.
I'd just like to know so I don't like, you know.
I do like a little bit of context being thrown in here and there, because you'll be surprised what I don't know. I mean, it's just,
Right.
but I don't wanna slow you down.
No,
So
that's fine.
don't worry about over-explaining.
Yeah, right now we're just gonna go over the
Okay.
software and everything, and then we can,
Great, thank you.
I mean, the fun stuff is the other stuff.
Okay.
So, when you're in here, you can label, and you basically just click on these clock hours here. These are all your clock hours. You can type in here, so say you see a tear, you can say tear at 1, and, you know, once you put a clock hour in there, it will automatically bring that label in here. And then when you save it, all of those annotations will be saved on the image as well. This is your anterior posterior labeling here, so this is actually a great tool to help you familiarize yourself with where pathology is within the eye, pathology and normal anatomy. And then this right here, you can actually input a protocol. So a lot of teaching institutions, like when I was working, I had a protocol that I followed with every single patient. I didn't have time to stop and label every image because I was scanning 70 patients in a day. So you can actually preset your protocol so that as you're scanning, it will save and label the image for you. That's what this drop down is for.
That's nice.
That's cool.
Yeah, and it's a really, you know, a lot of the docs love it because it's a time saver.
And they can compare one to the next, and it's always the same.
Exactly. So if that same patient comes back next week, you've got everything labeled and you can follow the same protocol for a comparison. So that's the left side of the screen. On the right side, you have your image settings. So this is your gain. So this is, you know, if you want to make it brighter or darker. And this corresponds with the red knob here. So, and you can see the same icon that's here is above that knob. Okay. This is like a line smoothing, and I can honestly tell you, no one uses this. Don't even worry about touching it.
Is it just set at a certain parameter or not?
It's just off.
Okay.
Yeah, it's just, you know, at that point, you don't want to start messing with the image, because
Yeah.
then you could obscure pathology,
Yeah, okay.
or make it look like there is pathology.
Okay.
Log is basically like a contrast. So if I have a patient that comes in with like a really bad traumatic injury and I can't seem to get a good image, you can change this log so that it just brightens it up. So if there are, like if it's a disorganized globe, that will kind of bump up the contrast. So maybe you can see the membranes or what's in there a little bit
Foreign
easier.
body.
Yeah. And you just basically, you know, drag it with the mouse. Time gain compensation, you just want to keep that checked off. Don't worry about that either. And then, because it's just a preset, it's just how much power is coming out of the probe. And then you have your media velocity. Okay, so this is important if you're scanning an eye that has a silicone-filled globe and you want to do some measurements on it. This is also really useful in what's called a B biometry. So if you do an immersion B scan, say you can't get an A scan or you're getting really erroneous A scan measurements, you can do what's called an immersion B scan. And you can measure each chamber of the eye using the correct velocity, and it will automatically adjust the measurement for you.
Depending on the chamber.
Depending on the chamber, exactly.
How many chambers are we talking about? 4? Oh, you're talking about chambers, you're not talking about quadrants.
So
Right,
you're-
right, right.
Yeah, I know what you're
Yeah.
talking about. You're
So
saying-
you do your AC, your lens, and then your vitreous.
Okay, all right.
And it adjusts everything for you, so you
Yeah.
don't have to
Okay.
do any kind of silly mathematics.
Yeah, that would take all day.
What's that?
It'd take all day to do the math
Yeah, I
by
know, I
yourself,
can't.
figuring
I
out the
mean, silly.
velocity
Yeah.
of each thing, each media.
And then under here, you have your zoom, navigate, zoom in, zoom out, you can crop, you can, go back to original, all that kind of thing. And then you have editing tools here. So you can put a marker to point at something, you can put a text box.
Ooh,
I'm gonna be honest with you, no one uses these.
really?
Really?
Yeah.
I would.
Yeah. I think the arrows are good,
Yeah.
especially if you're looking at something really small and you want a physician to notice it. The text, you can use, but you can also type in here, so, it just depends on what you like. And then clear all gets rid of anything that you put on here. This is a measurement caliper, so very important. This is for your tumors,
It's measuring in millimeters.
not measuring in millimeters, correct? So you can do your height, width, and length for any type of lesions. Or sometimes they'll ask, a physician will ask, how far away from the nerve is the hemorrhagic choroidal? How far away from the nerve is the tear or the retinal detachment? So that's a measuring tool. And then this is an angle tool.
A
So
what?
on a UBM, you can
Angle?
measure an angle. It's not like a volumetric, so it doesn't have like an algorithm in it for that. Like an area type thing, it's just your angle. Okay, and then you can undo. So say you wanted to keep, one measurement but not erase them all, you can just scroll through your undo. And I'm gonna undo all. And I'm gonna get rid of that text box. Okay. So those are all your tools here. Now these are your image trays right here. This is where your images will save. So, and also the foot pedal is down here. So, the right foot pedal or the left foot pedal is labeled here. So if you forget, left foot pedal is to start your scan.
Whoa,
Okay,
you're gonna send me on. Wow, you're a pro.
this is all I've done for the past 13 years. So I can do it in my sleep.
Hopefully you're left eye dominant
Hmm?
to see the screen with your.
Yeah, I actually have a really bad old corneal scar on my right eye.
Ah.
So it's concave instead of convex. So I see double, because I'm supposed to have laser, but I keep pushing it off. And my right eye sees a little bit double.
Go see Dr. Rao at Leahy.
Yeah, I know. What is it, Dr. Rao?
Naveen Rao.
Okay.
He's a cornea guy.
Okay, I'll have to look them up. So once you have your image here, you can, if you want to save a movie, you've got to save it before you start that foot pedal again. So you're gonna click on the movie reel. And you can have this box come up if you like it. This is just a labeling box. So if you don't have a protocol in there, this will come up every time you go to save an image. So I can say my horizontal axial, and I'm gonna label that, and the movie will save. Movies are extremely useful when you're first starting ultrasound because you don't have to worry about losing any information. It's also good to pick up any type of kinetic movement. So is this membrane mobile? Is it non-mobile? Is there vascularity within a tumor? Just immensely useful. Okay, so this is gonna save as a movie. So what I did was I did my scan. I start, stop on the same left foot pedal. And again, to save a movie, you're gonna click on this little movie reel with this floppy disk.
Otherwise, it just defaults to a still image, is that correct?
So if I kept going, I would lose everything.
Okay,
It doesn't automatically save.
yeah, okay.
If I don't want the movie and I just want a still, I'm gonna click on the right foot pedal,
Just,
label. Or you can click on this guy right here. And any button on here, if you hover over it, it will tell you what it is.
So you're saying you don't have a foot pedal for saving a movie, you actually have to just go on there and save it?
Right.
Okay.
Exactly. And it's just a way, a lot of folks, especially in larger institutions, they don't want a lot of movies saved, number one, because they can't export them.
Yeah.
And number two, because it just fills up the memory really
Takes
quickly.
space, yeah.
So you save movies when you have to, or when you're learning, and then you can always delete them later.
Can you save a picture from a movie?
Yes.
Okay.
So that brings us to, so I'm gonna click on this movie, I'm gonna double click it to load it. And then you have, so it's 254 frames here. So you have to be aware when you're scanning, don't just keep going, keep going, keep going. You've gotta be cognizant because everything that you have just recorded will be recorded over, cause it's gonna surpass the frames. It's just gonna keep moving. So if you see something,
I didn't understand that, I'm sorry, could you say that
so,
again differently?
so as you're scanning, you'll see this kind of ticker here.
Yeah,
It will go to 254 and then it will stop.
okay.
And then it will record over those first 254 frames that you had.
Oh, your limit is 254 frames, so if you're just
Exactly.
sitting there, you're doing 5 times 254, and you're only getting the fifth one.
Exactly,
I see, okay.
exactly.
And how long does it take to get to the 254
I
frames?
think it's about 10 or 15 seconds.
Oh, that's pretty
That's how
long.
long the movie is, yeah.
That's pretty long.
And so, you know, once you have your movie there, let me load this. Or even if you don't have it, even if you don't want to save your movie, once you freeze that foot pedal, just gonna go back to the beginning here. Once you freeze that foot pedal, you can use the Cine Loop knob, okay? And that's gonna scroll through each frame, and you can say, I want that one. And then I'm gonna click on the right foot pedal, label, and it will just save that frame.
I could see why that would be really useful when you're first learning.
Yeah,
Because
absolutely.
otherwise you can't aim, you don't even know what you're looking at.
No,
I still
and
can't even figure out what up and down is on it, so,
And
yeah.
you know what's funny? It's funny that you say that because when you're first scanning and you try to get this image, most people get it when they're not even looking. So they'll stop looking at the screen and they'll look to see where their hand is placed.
Yeah.
And that's when they get it on the screen and you have no idea you just got it. So you have someone watching you and they say freeze, and you freeze the foot pedal and then you can roll it back
Oh, interesting,
and kind of go through.
okay.
And you can save as many of those as you want. And just so you know ahead of time, once you end the session, these are pretty much permanently saved. So you wanna make sure that they're saved under the correct eye, cause I did it too when I first started scanning, I saved everything under the right eye. And the docs were like, we didn't have any left eyes? Like, what happened? They were all right eyes today. So, you know, cause you're just on like autopilot. So always make sure you can change the eye. When you're in it, you can change the eye. So if I accidentally save this and it's supposed to be left eye, I'm gonna click the left eye button here and I'm just gonna resave that image to the left tray.
That seems like a good trick to practice.
So just double click on it, load it on the screen, and resave under left eye. It's not a big deal, and, whoops. I click too much, so sometimes I freeze the machine. I have no patience. So, and that's what I'm here for, so if that happens and you can't figure out how to resave it and you forget, just call me, text me. That's what I take calls for all week. Little things like that can make a big difference when you're using the machine. So on this, just to show you what it is, I'm gonna click on, so post-processing is something that you do after you take your scan. So if you wanna adjust, say you're looking for drusen or you're just playing around with the settings, I'm gonna click on this little box here that will activate my gain button, my gain knob, and then I'm gonna roll it back, and you can darken or lighten.
What do you mean after you've done it?
Yep.
Or you can shine a flashlight brighter or less.
Exactly. So if you take some images and you say, I don't know if there's optic nerve head drusen there, I'm gonna go back and look at the optic nerve, but I need to darken it a little because I can't really tell. You can go in there and really, you know, some people have set numbers that they roll it back to. I don't. A lot of places will go to 48 or 49, and that way you can really highlight pathology.
I actually have a question. How do you tell which is the front and which is the back of the eye?
So the left side is always gonna be, think of it where the probe starts. So the probe is on the eye.
Okay.
So this is where the probe is. The transducer is here.
Okay.
So this is kind of like the dead zone.
Okay.
And then you have your lens, so your iris is here. Let me put this up.
Thank you.
Your iris is here. Posterior lens capsule, vitreous cavity, and your retinochoroid sclera, and your optic nerve sheath.
Okay.
Do
Okay.
we have any indication of a muscle in there?
Of a muscle?
a
Yep.
reference muscle.
That's one of my muscles there. This is a muscle and this is a muscle.
And that's a geographic landmark for some people.
It can be, depending on the image. For this particular cut, my lens and my nerve is my landmark. Because what I want is a horizontal axial. Wherever you point your probe marker is going to be the top of the screen. And your probe marker normally is either going to be nasal or superior when you're scanning.
So what do you point on the screen where the top of the screen is?
Right here. So my probe marker was pointing nasal on the right eye here. So this is nasal and temporal. So in this image, this is basically, if you think of an A scan, this is your A scan in B scan form. Okay, so you have your anterior chamber, you have your lens, you have your vitreous, which would be the flat part, and then you have your retinochoroid sclerospikes here, and your orbital fat pattern. So this is the image that, and I always tell people, again, if I'm jumping ahead here, just stop me. Before I do an A scan, I always do a B scan. If there's no view in that eye, which is why they're having an A scan in the first place, if the cataract is that dense, there could be a tumor, there could be a detachment, they could be tisical, they could be, I don't know, they could have a big staphyloma. You wouldn't know unless you did this. What you do is just go and start doing your A scan and you're like starting to sweat because you can't get good readings, you're not understanding why you're missing some spikes. That's why it's always good to do this before an A scan, okay, because then you know what you're dealing with. And once you have this image down pat, as far as being comfortable with getting it, it takes a while to learn because the eye rolls. This is just invaluable, even if you hone your skills and get this image.
So can I ask a question? From
Yes.
the right to the left eye, it would always be nasal on top and
Yes,
temporal on the bottom, no matter what.
correct. On this image, it's always gonna be nasal and temporal.
Gotcha. And that would be just nasal and temporal placement.
Right, so this is going to be direct gaze, so the patient's not looking anywhere. I scan over the lids, but a lot of docs will have you scan on the globe. It's just a matter of
direct gaze
preference.
and then just nasal when you look
Right.
straight. Okay.
Yep, so the probe marker is at the nose. And
Mhm.
basically what I tell people is, you know, when someone has their eye closed and they're laying back, you can kind of see where the eye is rotated. So sometimes it's looking down, sometimes it's up, and you've gotta kind of chase the eye and kind of find it. And that's just part of learning how to do ultrasound. But if I do an A scan and compare it to this, it will match up. You know, especially if you've got a big discrepancy between right eye, left eye. Right eye could be normal, but then your left eye could be like really long and egg-shaped. You know, staphyloma, you've got a myopic eye. And that's a good way to double check your A scan measurements. So if you have one eye that's 23 and the other eye is 27, verify it with your B scan and you'll see the difference between both eyes, and then it will make a lot of sense.
Can you do supra and infra? Superior and then inferior for you as well?
Yep, so what you can do, so this is nasal temporal, and then what I would do is you can do what I call a vertical disc, and a lot of people will call it a vertical axial. So that's not me, I don't think. No. Okay. What you're gonna do is rotate your probe marker. Oh, that's coming from there? Okay, sorry. I thought I had my phone turned off. You're gonna rotate your probe marker superior, and then instead of being directly on the globe, you're gonna kind of rotate temporal a little bit so that you're more towards the limbal region. Because in this image, you wanna bypass the lens, and you're only gonna look at the optic nerve. And it will look like this. Not the best, but it'll make it work. Okay, so on this one, because my probe marker is superior, The top of the screen is gonna be 12 and the bottom is gonna be 6. So 12 and 6. But you bypass the lens. You don't want the lens in there, you just want the nerve. And this would be labeled as VAX, so vertical axial. And what you've just done, essentially, in those two images, if you looked at the posterior pole of all 4 quadrants. So you know at the nerve, there's nothing coming from, no membranes extending from the nerve, there's no tumors here, there's no detachments or pathology here. But what you haven't done is looked in the periphery. So some docs, I'm not gonna lie, will just go in and they'll just go like this and they won't see anything, posterior pole. But meanwhile, in the periphery, there's like a giant tumor or there's a detachment or there's a ski cyst. And so that's where you guys come in and you've gotta, is there anything in the periphery? You've gotta sweep the quadrants. And that's where your nasal, temporal, inferior, superior come in. Some people do what's called SNIT, just still to remember it, so superior, nasal, inferior, temporal. And like I said, everyone kind of follows a different process, but you're still doing the same thing.
So it's, never mind. I am super orientation challenged. I could spend
That's
2
fine.
days trying to figure out what you're talking about
Yep.
when you say nasal. I mean,
Yep.
it's just, I'm so challenged.
That's okay.
Yeah, so I don't need to get into it, but when you say superior, SNIT, superior nasal, inferior, we're talking about coming in superiorly and looking inferiorly, or coming in inferiorly and looking superiorly?
So with your B scan, your probe's gonna be on the opposite side of the eye.
Okay,
It's always gonna be on the opposite side of the eye.
right.
And essentially what you're doing, I'm really glad I have this board, because usually it's like I'm on a little piece of paper. Usually what you're doing is, I don't know where you can all see this.
I have a hard time directionally with B-scan as well. So when I was at KC, one of the sonographers that was learning had a foam ball.
I have my foam balls with me today.
Oh, really?
Yeah, I brought my foam balls because I just need to see it again. I cut open a tennis ball so that I could understand
Yeah,
it.
that's too close together.
Because when you think of that, she's taking just a slice
So-
through
Right.
the globe.
Yeah.
And so the transverse, axial, all those superior, inferior are all directional that
Right.
they label.
Okay.
So
I'm
essentially
listening.
what you're doing is you're gonna scan your
Okay.
nasal, say this is the right eye, your nasal and
Again, this is
temporal
as, we're
quadrants.
looking at them, right? We're talking about the fronts of the eyes where you've got your
Yes.
clock hours, that's what you're talking about, clock hours.
Yep, so you're
Okay.
looking at the patient.
Is this boring for you guys?
No, this is good.
Is this useful? Because I don't want to drag you down.
This is super
important. All right.
Okay. And this is just basics, and, you're gonna see it today, and then tomorrow you're gonna be like, what did I even
Yeah.
see yesterday? But that's normal. So, here's the nose. So you're gonna be cutting the globe nasally. So on your screen, you're gonna see 12, 3, and 6, 12, 9, and 6. And then what you do is you're gonna rotate your probe marker, and you're gonna look at the superior quadrant and the inferior quadrant. Your probe orientation is the most important thing. And also, you wanna make sure that you have the patient rotate their eye in the direction that you're looking. Okay, so if you're looking nasally, you're gonna have the patient, patient's head is here, then you're gonna scan nasal, you're gonna have the patient look to the left, look to the right. So always think, have the patient look in the direction that you're scanning.
So I'm scanning nasally, they're looking nasally, and I'm gonna see the temporal side of the inside of the
Exactly.
eye.
Yep.
Okay.
So, and that's gonna look like this. And this is why labeling is so insanely important, because you can't tell from a quadrant scan. It could be the right eye, it could be the left eye, it could be superior, inferior, nasal, temporal. That's why, and sometimes it helps to have like a regular old-fashioned clock in the room ahead of the patient. I always kept it when I was first learning. It just kind of brought me back to,
Some landmark is really helpful with this image.
Yeah.
Otherwise, they're just saying, do you see what I'm doing here? I'm like, well, no, because
Yeah.
I don't have any
Right.
landmarks.
And
Right.
sometimes, you won't know until you actually have the probe in your hand and do it.
Yeah.
I mean, observation is a big part of learning ultrasound, but you've got to get your hands on it.
Really? Too bad.
So what I'm gonna do is scan nasal. So I have my probe temporally,
And you're looking nasally.
and I'm looking nasal,
And your marker is
superior.
on top next to your fingernail, right?
it might be a little
It's
twisted.
right,
'cause
it's
of-
right there.
Okay,
Your
good.
white marker is there.
Okay,
Okay.
so what I'm gonna do is look to the left, and I'm gonna scan anterior to posterior. So essentially what I've done,
So you scan
Is
up and
looking-
down, anterior to posterior.
She's,
12, 3, and 6, and see how when I sweep, I'm basically scanning the sound wave up to the top of the eye and back to the posterior pole of the eye, up to the front, down to the back. And it's a very small movement. You're not moving it up across the eye like this. You're literally just angling the sound up and down. And in that scan, I now know that between 12, 3, and 6, posterior and anterior, that was my lens, there's no pathology. So on a fundus exam, they can't see any of this, so that's where the ultrasound really comes in.
what do
And
you
can
mean they
see-
can't see any of it on a fundus exam?
Unless they scleral.
All because they can't,
They
yeah,
can't,
they
there's
can't
no
pop into the inside of the interior inside.
Well, they can on a scleral depression exam, but if there's a vitreous hemorrhage, if the cataract is
Oh, I
too
see,
dense,
because there's
if
too
they have
much
an opaque
opacity.
cornea,
There's-
this is what they're gonna be relying on. This is your number one, this is your primary mode of diagnosis.
You're talking about sound versus sight.
What's that?
Sound
Yeah,
versus light.
right.
Right, okay. And images and
Exactly.
light, and this is sound.
Yep.
Okay, these are the basics that I need to come in with. Okay,
Yeah.
I understand.
So in here you can see, okay, that's up. This is my pupil and my lens here. Now, I wouldn't save it like that. And the reason being is that if I show a doctor this, they're gonna be like, okay, do they have a coloboma? Is the eye icicle? Like, is it hypotenuse? What's going on here? When really, that's what the globe looks like. So if you think of the eye like, like a globe, and you have your equatorial region right in the middle, that's where your landmark is. The widest volume of the globe, if you're thinking of it, a sphere. That's where you want a landmark, because this is gonna be your, basically identifying that there's no pathology in that quadrant. If there is pathology, then feel free to, you can roll back and label anything you want. If you wanted to send this, you can say, nasal anterior view, or whatever, you just label it. That's what, where labeling comes in. So in this image, we see some vitreous debris. I have a PVD in there, which you can see is here. You can see that the retina choroid scleral layer is normal, and you can also see a transverse view of my muscle here. So if I turn the skein down, that's a transverse cut of my medial rectus right in here. I won't get too much into detail because I don't want to confuse everybody. So what I would label that as nasal. Okay. Now, I've done nasal, now I'm gonna move on to temporal. So my marker is still gonna be at 12, still gonna be superior, only I'm gonna be in at the bridge of the nose, and I'm gonna have the patient look to the right, and I'm gonna scan anterior to posterior. Anterior to posterior, and then I'm gonna landmark. Yeah. Okay.
And are you still missing the lens?
What's that?
Are you managing to get behind the lens still?
Yeah, so what you're doing when you sweep is you're getting all the way up, so you're pointing the sound up at the lens, and then you're pointing it back towards the optic nerve. Now, you won't always see the optic nerve just because everybody has a different shaped eye, people have different anatomy, the nasal bridge. So sometimes when you're doing your temporal sweep, sometimes it can be kind of hard to get a good sweep in there. That's fine, as long as you're noticing that there's no pathology here. Another important thing too when you're scanning is to always brace your hand. So brace this part of your hand on the patient's cheek while you're scanning. Because if you're just scanning along like this, your hand's gonna move, you're not gonna get, you're not gonna get good images. Also, if the patient just decides to pop up out of the chair for whatever reason, which it does happen every so often, you're gonna impale them with the probe. Whereas if you have your hand braced, that's gonna be kind of a deterrent for that happening. because you're gonna be able to lift the probe like this.
If you do impale them with the probe, at least you're right there with your probe to see if you cause like a vitreous hemorrhage or something.
Well, yeah, but
I'll sit back down and see.
hopefully in that case,
Hopefully
that would be
not.
like a really rare occurrence, I would hope.
Specific for dilated patients, best to have an angle closure attack at the clinic.
Yeah, right.
And so that's another reason why putting this around your neck like that is really helpful, because you control how much slack there is. So I've had patients grab, mentally challenged patients, you never really know, because it does happen. I've had them grab the probe from me. You just kind of have to be, and there's a lot of ultrasound, and doing ultrasound is social cues too, reading your patients. And knowing what they're comfortable with and what they're not comfortable with. So on this image, we have 12, 9, and 6. So 12, 9, and 6, and everything in between. Okay.
Yeah, I don't see that, but I'm gonna have to work on that.
And it's all just getting to know the physics of ultrasound. It doesn't happen overnight.
You're,
Not about 2 years.
you're also not gonna walk into a clinic and just start doing B scans either.
Right.
And I think
Well, some
your
physicians
ultrasound
will-
lecture is next term with advanced diagnostics.
It's useless.
Some physicians will just say, here, do a B scan. And it's not, you haven't been trained. It happens to technicians everywhere.
Yeah.
And they you just kind of
When-
learn by baptism of fire,
Right.
But I have been in situations like that.
So how many B scans have you done in your professional
Me?
life? Yeah.
Well, we only had a B scan at Vancouver Clinic,
So
so I probably only did like maybe 8, 10.
how many
at
have you
most.
done? 0, okay, all right.
I love that.
And we had the easy B scan,
Right.
A B scan, the one that,
Yeah.
it's called easy B scan.
Yeah.
So where does a LensStar and an IOL master fit in?
Those are optical biometry, so
Yes,
that's an
IOLs.
optical
It's a
A
light
scan.
thing.
Yeah.
It's a
Scan I
light
did
thing,
a
not a
ton of.
sound thing.
Right.
And so if you don't have a light for it, you need to do the sound waves.
Right, so,
Okay.
so essentially, if your patient has, 90% of patients have a clear enough media to get an IOL master or LensStar,
Yeah.
those 10% that don't, you're gonna do either a contact A scan or an immersion A
Okay,
scan.
that gives me some great context.
Yeah.
Okay.
Yeah.
And you want to almost always, if you can, do immersion, only because it's more reliable.
Oh.
And I'll show you why when we get into A scan.
Yeah.
Oh, yeah. Sorry, I can't even.
For example, if patient have contact lenses on, do we have to take them out?
If you're gonna be doing the scan on the open globe, yes, they need to come out. And usually when people scan on the globe, they'll put, proparacaine in and then do the scan, but you need a lot of genteel because you don't wanna break the cornea. That's why I don't like doing it on the globe, but some physicians will tell you that the eyelid will attenuate the sound, so you're gonna miss a little bit of vitreous opacities. And sometimes it's true, you can go on the globe to get a better image. But, it really just depends on what they prefer.
So there's lid, there's globe, and then there's immersion?
Well,
Not really.
Not
for B scan, you're gonna do, for B scan, you can do it over the lid like I'm doing.
Yeah.
You can do it on the globe with proparacaine and a lot of genteel. And if you couldn't get an A scan, or if you're getting erroneous measurements and you wanted to do kind of that immersion, or, immersion biometry B scan, you could do that as well.
Yeah.
That's if you're gonna be in I can tell you, most people don't ever have to do that. If you're coming from a situation like I came from, and we had a separate ultrasound lab that we did everything, that's when it kind of becomes a little bit more common. But it's good to know that you have a backup technique if you needed to use it, if your A scans are extremely erroneous.
Dumb question.
Yeah.
Is that immersion with the IOL similar? Because I had a patient that they couldn't get the measuring in the eye for cataract surgery.
Yep.
So they took him to the immersion, which is like they fill up with the liquid.
Yep.
And
That's
is
immersion
that-
A scan.
Okay.
Yep, that's exactly what it is. So it's just two different cups.
Yeah.
So for the B scan, you would have to use this one because it's bigger. Because that little one, the B scan wouldn't fit in.
I see.
So these are called Hansen shells. These are scleral shells.
Oh. Oh.
So your B scan can fit in here with saline.
I got it.
And you can use these for, you know, a lot of people were trained to use UBMs with this, but clear skin bags are better. I'll explain that too. How much time do we have left? I don't wanna get.
An hour.
An hour? Okay, good. All right. So I'll go through the rest of that protocol real quick with B-scan, and then we can move on to the other modalities. That way you have, kind of can ask questions about each one. So you got nasal, temporal. So now for inferior, I'm gonna rotate my probe marker towards the nose because I'm gonna look at the bottom half of the eye. So now we're on that second image there. I'm gonna have the patient look down, and I'm gonna scan. I'm gonna scan anterior to posterior. Now, inferior and superior, if you're doing the scan through closed lids, it's very difficult for a patient to look down and up with their eye closed. So you can have the patient open their eye, look down, but you're still on the lid. And you really wanna you don't wanna be like this, you wanna be like this, you wanna be perpendicular. Always be perpendicular to the globe. Because if you're like this, you're gonna be going through the lens. But if you go up towards the brow bone and point down, so you've gotta point your sound towards what you're trying to scan. And that's all what it is. It's all about being perpendicular. That's how you'll get an image.
Perpendicular to the globe or perpendicular to the brow?
Perpendicular to the globe. So if I'm at an angle like this, my sound is going straight through to the back of the eye. It's not going inferior. So you've got to almost picture a fan coming out, the sound. And I'm angling the sound wave. Okay, so now what I'm doing is scanning 3, 6, and 9 here. Okay, because my probe marker is at the nose, which is here. 3, 6, and 9. Whoops. My mentor always told me I needed a pointer. She's like, you just gotta stop touching the screen. 13 years later, and I still haven't stopped.
And where is your marker?
Your marker is at the nose.
Is it 3? So
Correct.
patient's looking down, so you're sweeping the superior.
You're sweeping
Right.
inferior. Yep, you're sweeping the inferior quadrant.
Oh, I see, you're going,
Yeah.
okay.
So your probe is quote unquote superior. So
Yep.
it's pointed inferior.
Exactly,
And the person is looking,
correct.
I thought they're supposed to look, because they look the direction that you're
They're-
trying to scan.
Yep, so we're scanning inferior, so I'm looking down.
But your probe is superior. Okay,
Correct.
all right,
The probe is always opposite.
Yeah.
right,
Yeah.
okay.
I have a question.
Yes,
So I'm looking at that diagram, and how you said 3, 6, and 9?
yep.
Is that always the direction, and 12 is the start, and where it starts?
Is it always, say that again, sorry.
So you said 3, 6, and 9?
Yep,
So 12 is here?
so 12 is at the top, so you're just bypass, you're not.
No, I'm looking at your image. You said 3,
Up
6,
here?
and 9.
At this one or on the,
No, that one.
this one?
Yeah.
Yeah, so 3, 6, you're not, 12 is gonna be over here. 'cause
Right.
it's- Yeah,
Is that always the case?
it depends on where you're, what eye it is and what clock hour you're scanning, yeah. So
So
the,
like
the
with the
opposite of where
temporal
you're
here.
scanning is always gonna be kind of off the screen. You're not gonna see it,
What'd you say?
so, cause it's gonna be near the dead zone,
Right, okay.
yeah. I never thought of it like that because if I did, I'd probably get confused.
Okay.
But yeah, so just think of whatever's on this side is basically where the sound is coming from. So your transducer is on this side. So if you think of kind of a fan coming out and a fan coming out, sometimes, you know, people will take a pen and they'll put a piece of paper on it that looks like a fan, like a sound wave. Sometimes that can help you kind of, you know, everyone has a different thought process, so,
Yeah, that's for sure.
you know, it's just, there's no one way to get around it, you
And
know?
in books, it's all two-dimensional, so anything three-dimensional is just
Yeah.
pointless to
Right.
teach in a book, yeah,
Yeah.
right.
But a lot of people think that, and then they wind up
Uh-oh.
getting proficient in ultrasound, so, you know, you just kind of have to kind of interpret in a way that you can understand it.
So when you are scanning anterior, posterior, you're going from temporal to nasal,
So I'm going
or more
Down.
that way?
and back. So don't forget, I'm scanning up towards the front of the eye
Anterior,
and back towards the back.
posterior, gotcha.
So kind of think of it like a
So
windshield,
like a different
windshield washer,
axis.
you know?
Yeah, okay.
When you go posterior, are you going to the equator or not necessarily?
You're going past the equator back to the nerve.
Yeah, okay.
Yeah, but you're getting the equator in there.
Yeah,
As you're,
right,
as you're
okay.
scanning.
And are we saying equator, like there's only one equator
There's only one equator.
in each eye?
Yep.
We're not
Yep.
deciding what meridian is halfway through, because there's, I see.
Right, and that's where this little diagram kind of gets, it can get pretty confusing,
Yeah,
you know, and you've gotta kind of, you know, always remember that the equator is gonna be the widest volume of the globe. So you're gonna have a nice round, if the eye is normal, you're gonna have a nice round posterior pole here, or ocular wall. And then you'll just, you'll know if it's abnormal, you'll know.
okay, just so I'm clear, so the equator is parallel to the lens in the cornea, not across. The equator runs this way, and so here's your lens, here's your cornea running, I'm making a disc, I have another disc, and the equator is going this way. We're not talking about an equator here or an equator here.
Right,
We're
well,
talking-
yeah,
We're talking about one that's parallel, I'm sorry, I don't know anything.
yeah,
So
I don't know,
parallel,
now I'm thinking about it and I'm getting confused.
Right? Because the equator in the earth
Yeah.
is actually
It's
across my
horizontal.
belly. It goes through the belly,
Right.
right.
Yeah,
But an equator on the eye goes up through the North Pole and the South Pole. Or which way is it?
I think it just depends on where you're pointing your sound.
So an equator could be any one of those meridians as long as it's cutting through the
Yeah,
fattest
and
part.
by equator, we're talking about the middle of the eyeball.
Yeah,
So you're talking about the middle of the eyeball. I still think of it as horizontal.
Okay, well, I just think there's two.
Because there's two ways that you can point your transverse, you're looking at it horizontal. Then your longitudinal, you're going from cornea to nerve, like this.
Okay.
So
I
it
think
does
it's-
depend on where you're putting your sound. And I'll show you that too.
Okay.
so it depends on your orientation.
So the
Yeah.
equator can change.
Yeah,
Oh, so it's not just one line.
right.
Okay, that was my first
Yeah.
question. Okay,
Yeah.
so it can change.
So it can be longitudinal and,
It's
kind
just
of
one of the
horizontal.
meridians that's in the
Horizontal.
fattest part of the eye, depending on the way that you're looking at it. Okay,
Think about it like an X and a Y axis.
Right,
almost.
exactly.
except that there's more than two,
Yes.
right?
Yeah.
well, and I tend to think, when I look at
Depending on
a
the
still
orientation.
image of a B-scan, for me, one way that helps me understand it is I'm looking at like a histological slice of
Yeah.
tissue.
Right,
It's just like a thin sheet
Yeah,
of an image.
right.
And when she does the video, you're putting all those thin sheets together to look at whatever,
Exactly.
maybe a 45-degree view or something like that.
exactly. That's a good way to think of it.
But I get totally confused with the directional and
And
transverse
even,
and axial and all
you
that
see
stuff.
me, I've been doing it for so long, and sometimes if I hear it, something described a different way, I'm like, wait a minute, have I been wrong all these years? You know, you're like, just because, you're looking at something flat, and you're supposed to think of it as a round object in your head.
Herein lies the problem, yes.
And it's still, and that's why one thing that really helps is like fundus drawings.
Yeah,
So when you do a B scan, do all of your images and then take them and draw your fundus image. How far from the nerve does this thing go, or how close to the nerve is this pathology? And that's one way that kind of helped me do a 3D image of the eye from these. Okay, so that was inferior, and now we're gonna do superior. So
So then you have the patient look up.
yep. And you're gonna be, so your probe marker is still at the nose, and I'm gonna look up, and I'm not gonna be like this, because then I'm gonna looking at the orbital bone. I'm gonna be perpendicular to the eye, that's what I mean when I say perpendicular to the globe. And I'm gonna scan anterior to posterior. Now, when you're scanning superior, if you're on the eyelid, you're gonna feel like you can almost like see how much pressure you're putting on the
Yeah.
globe. It's like now there's two of you, because I'm pressing on my eye too much.
there's too many of them.
And that's another thing, is learning how much pressure to put on the globe. So that's why practicing on one another is really useful, because you're not afraid to tell each other, like, all right, you need to like stop, because, the eye can take a lot, but the more you push doesn't mean you're gonna get a better image. Okay, you're just gonna be annoying the patient,
How about,
or one another.
how about if you do less pressure?
If what?
Less
pressure?
So sometimes you can do too little pressure too. And what will happen is,
Good question.
you won't get an image. See that?
No.
See how you're not really getting an image there. I'm barely touching my eyelid, but if I go on the globe with just enough pressure, I'm getting it. But see, I'm pushing harder, the image isn't changing, I'm just hurting myself. Now if I'm not putting enough pressure, you're gonna be like, why can't I get this image? It just doesn't look right. And there you go. So it's a balance, and practicing on each other is the best way to figure that out. I always tell the story of, there was an RN who did an ultrasound, you know, a couple of years before I went to Mass Eye and Ear, and the patients called him Todd the Impaler.
Oh, gosh.
So, and patients remember that. You know, patients remember, even if it just happens once, they remember who hurt them and when. So that's where practice is really important. Okay, so on this one, we're looking at 3, 12, and 9. Okay, so 3, 12, 9. So those are your quadrants. If there's no pathology, you can stop there. You've scanned anterior and posterior of all your quadrants. You've looked at the posterior pole of all your quadrants. So you're good. If there is pathology, or if there's no pathology, but you still want to document the macula, you can do a longitudinal cut. Now this is the one that kind of confuses people a lot. Okay, I'm just warning you. So you're basically going to aim your probe marker at whatever clock hour you want to look at. Okay, so if I want to look at 12, I'm going to aim my probe marker at 12 while I'm down at 6. If I want to look at 3, I'm going to be at 9, pointing my probe marker at 9. And what that's going to do is give you one cross-section of that one clock hour from posterior to anterior. Okay, because if I'm looking here, my probe marker is facing towards the cornea, so that's anterior. Anterior will be on the top of the screen, and your nerve will be at the bottom of the screen. It'll look like this. Okay. So this is just 12 o'clock. This is not quadrant, I'm not sweeping, I'm not doing anything. The nerve is here. This is 12 o'clock posterior, 12 o'clock equatorial, 12 o'clock anterior. Excuse me, I get dry after I've talked for a while. This image is where you're going to look at optic nerve drusen. Okay, so you're going to look at the apex of the optic nerve here. You can look at muscles. Just show you what that looks like. So, okay. So there's my nice little floater there, and I have here my nerve, and I have my medial rectus here. And so the opposite is, like you kind of brought up earlier, the opposite side is going to be if this is 3 o'clock, then this is 9 o'clock here. So if you're trying to like figure out where the pathology is and you see it on the opposite side, you'll say, okay, it's not at 3, it's at 9. And then you can also do, and these all look the same, and that's why labeling, again, is really important. So if I wanted to look at the macular region, because I can't get an OCT, and I just want to document that it's normal, I'm going to point my probe marker at 9 o'clock, and with direct gaze. Here's my nerve, and here's your macular region right in here. Okay. So now, what's interesting about this is the eye moves. Okay, so if I say, you know, I really think I saw something in the anterior periphery at 9, I want to try to get that information. So what I'm going to do is have the patient look, and as a compromise, you're going to lose the nerve. You're going to lose the nerve at the bottom of the screen because you've rotated the eye back, but you're going to get more anterior information. Okay, so there could be a tear, there could be a schisis, there could be some sort of pathology. And so if you're not seeing it with direct gaze, just have the patient move their eye. So look towards 9 o'clock. You will lose some of the nerve here, but you'll gain your anterior. Okay, so that's kind of the basis, and I would name that, I would label that L9. So longitudinal at 9 o'clock.
So when their left eye is looking at 9 o'clock, their left eye is looking to the right.
Yes.
Okay, and when their right eye is looking at 9 o'clock, their right eye is also looking to the right.
Right.
Yeah, okay.
Yeah. Yep. So you just have to think of it as you're looking at, just picture looking at the patient's face and where they would look. Okay, so any question, and then here are your tools here. So we've gone over your gain, your movie, if you want to measure something, and you can move these around. You can edit them, and you can do this all post-processing. So if you've already ended the session, you can go back in and do that. Okay. Save that.
What if you want to delete that arrow
But you can't
after
tell
you
them to
save
look at
it?
9 o'clock.
If you wanted to move it.
As in, like, delete the arrow, that yellow arrow?
Oh, yeah. So this one, this is the caliper. You can click on it and get all up on the machine like I do. Move that. You can edit this, and then if you wanted to put an arrow in, you just click this.
Mhm.
And again, you can do the same thing with that one. You can move the angle of it, as long as you click right on it. You can move it around. And then if you want to save your image with your changes on it, you're just going to click that button, or click your right foot pedal. Okay. Okay. Any other questions about B-scan?
Yeah, you can't tell them to look at 9 o'clock, so look the wrong direction.
What's that?
You can't tell them to look at 9 o'clock, because they'll look at the wrong direction.
The patient?
Yeah.
Yeah, no.
Yeah.
I usually just say, and sometimes tactile reminder works too, because,
Yeah.
when patients are laying back, you'll say, look left, and they'll look like this. They'll look kind of down, and you just say, no, look here, and they'll kind of,
The reason I ask that is because it comes up on test questions, and it's never clear if you're talking about from the patient's view or from, and you're
Right.
supposed to know that only the tech would ever say 9 o'clock for the tech and not.
Exactly.
Right.
Exactly. Look to the right, look left, look up, look down. Or if you're looking at 1 o'clock, look up and to your right, look up and to your left. And so you would do the same thing for those oblique kind of clock hours, and when you're doing your transverse, your longitudinal is always 90 degrees away. Okay, so if you're looking at 12 and you wanna say, okay, can I see the same thing on the longitudinal, you're just gonna rotate 90 degrees, okay? All right. Just like a little alcohol or something. I just don't want that throat to get all gross. Okay, thanks.
Push down the top.
Push it? Okay. Oh, it's like the nail polish remover.
Yeah. It is.
Got it. That's how mine works.
A lot of that here.
I need to do my nails, speaking of that.
No, she said too much.
My daughter likes to paint my nails sometimes,
She did it today, right?
I'm so used to just the alcohol prep
All
tips
right.
and I just,
Oh, yeah.
right?
okay. So,
A-scan?
next is UBM.
Oh.
Which stands for what?
Ultrasound biomicroscopy, which really, it's not a biomicroscope, it's an ultrasound, so it's just, have you seen those old ones, like with the arms? So they used to have like robotic arms, and the patient would have to be strapped down, and there'd be like a big thing of water.
For UBM?
Yeah.
Oh, wow.
And
That's how
you
when they
said
first
this
came out.
this correlates to what are we using this for?
So UBM is
For
gonna look at, and it probably will make more sense if I bring up an example here.
UBM's looking at anterior segment,
Oh, okay.
Yep.
So the
structure.
modalities are based on.
Yeah.
So iris cysts, iris tumors, ciliary body tumors?
A lot of glaucoma docs will use it to look at cysts before they'll do like a PI or something.
What's
Um,
the PI?
Peripheral iridotomy.
So many vocabulary
And you can see,
words I
you can
don't
check to
know.
see whether they're painted or not. That's probably the
Yeah.
worst example to bring up when you first are looking at it. So you can actually see the
Yeah, I
PI
honestly don't
if
care.
it's
I
painted.
could've just
Yeah.
left it on
With
there.
the
I was like,
UVM.
So it's
screw it, but
actually
I was
See if it
like,
actually
successful,
works, yeah.
But I don't.
Did you do an ultrasonography program before you got into it, or were you just sort of thrown
Have you
in?
guys heard of Rhonda Waldron?
Oh, yeah,
She's
in
at Emory.
Atlanta?
Yeah, so she
I
actually,
heard her speak one time.
yeah, so she used to do like weekend workshops. She's not doing those anymore, but,
Yeah, she's getting older, isn't she?
she is. But I think it's more like, she's still working at Emory, she's still doing everything,
Yeah.
but, I think they just they couldn't fund it anymore.
Sure.
But she will come out and do like a training course for credits. She's supposed to be working on something with us towards the end of the year, hopefully that happens.
With Ellex?
Yeah,
Oh, cool.
yeah.
I haven't decided yet.
So is that how you sort of got into this stuff, or did you go through like a formal ultrasonography?
No,
program?
so
Okay.
I started out working at lunch practice,
Oh,
and I
okay.
just did a little bit of everything,
And
then
then
I-
went to ophthalmology?
I loved it.
Yeah.
And I wound up at private practice, and then I went to Mass Pioneer, and they had an opening, so I learned on the job mostly. So this is gonna be, your most common UVM image. So this is gonna be straight down through the cornea. So the difference between UVM and B-scan is that on UVM, your probe marker is gonna go on the exact clock hour that you're looking at. Okay, so if you're looking at the eye, if you're thinking about it like a corneal image, not a fundus image, you're gonna look at it like a cornea. So you're gonna have the eye here, and you're gonna have all your clock hours here. Okay? So your probe marker is always gonna be facing towards the cornea. Okay, so this is your limbal region here. And this is your axial view here. Kind of like a target, pretty much. So with your, and I'll go over setting up the probe too with you guys. So your probe marker, this one's a little bit bigger. This is your probe marker here, this little screw there. And instead of being, you know, if I wanna look at 12, I'm not gonna go down here at 6. I'm gonna go right on 12 with my marker on 12 o'clock, pointing towards the cornea, okay? Now, that's gonna be a longitudinal cut, which is just gonna give you, it's gonna give you one slice. So if you're looking, it's almost like an anterior segment OCT. So you're just looking at that one slice. You're gonna have your, so picture it just this one side. You're just gonna see your cornea, your limbus, your angle, iris, ciliary body, and the lateral aspect of the lens here. If I were to rotate my probe marker on the same clock hour, 90 degrees, either right or left, doesn't matter, I'm gonna be doing a transverse cut, where you're gonna look at your ciliary processes. This cut is gonna be an axial, so I'm gonna be going straight down, and you can either, point your marker toward, you can point your marker towards the nose, and the right side of the screen is where your marker is, and your left is the opposite. If you did it the other way, that's fine. You know, if your probe marker pointed temporally, you just have to remember whatever clock hour your marker is on is gonna be the right side. Okay, so you might have it flipped, 12 to 6 or 6 to 12 or vice versa. So on this one, I'm not sure which clock hour, it was probably nasal, so this is probably, you know, the right eye, it could be 3, or this is the left eye, so this could be 9 and 3. And this image is gonna give you your anterior chamber depth. So this is where you would use this velocity change, okay? So I wanna measure the AC, so I'm just gonna do it on aqueous 1532, and I'm gonna measure from the cornea to the anterior lens capsule, and some people like to do it from the inner cornea to the lens capsule. And I have that, and now I'm gonna change it to lens, and I'm gonna measure from the anterior lens capsule to the posterior lens capsule. So in there you have your different measurements with your velocities taken account for, and we have a pretty accurate measurement. Sometimes we'll do these for patients that are gonna be getting a K-Pro, where they don't necessarily need like a really accurate axial length, they just need to know how thick the lens is and various other measurements, so they can put a K-Pro in, you know, how deep is the AC and whatnot. So this is just another way to do that. Okay, so, and again, you can do the same thing with the sitting loop here. This is an ICL, so you can actually see that the ICL is in the sulcus, right in here. One of the worst possible UBMs that anyone could ask you to do is to, can you find the haptics?
Oh, God.
And you're like, everyone, even Rhonda is like, ugh, when it comes to looking for a haptic. We've been doing it for 40 years.
Just because they're so small, or the reflectivity, or what is?
It's just, if you don't hit it perpendicular, sometimes you can't find them.
Oh.
Or if they've moved out of the capsular bag and they're just
Yeah.
kind of floating around, it can be hard to find them. Common indications for UVM, obviously tumors, cysts, but also looking for IOL placement. Sometimes if it's out of the capsular bag and you have one of the haptics that's kind of poking through the iris, causing a little bit of a hemorrhage, that's a very common request for UVM. But mostly you're gonna see cysts and things like that.
So this is an ICL in a phakic patient.
Yeah,
So this is anterior crystalline lens.
correct.
Okay.
You can see this.
Yeah.
Yep, and then when you roll it through, you can kind of see you can actually see the zonules there.
Yeah.
So holding on to the lateral aspect of the
Okay.
natural lens, and then you can kind of see a little bit, you can see both, you know, borders of that ICL. Looks like it's all bunched in there.
I was
Makes me
gonna say, that
nervous.
looks pretty crowded.
So these are just some small ciliary body cysts. You can see that here, right in the ciliary body. This is a longitudinal that I was explaining, so you'll just see one kind of area, one cross-section of that angle. And you can, the good thing about using the clear scan bags, which I'm gonna show you now, is that you can go farther back onto the sclera. So you can, yes, you can get your anterior views and everything, but if there's a tumor that's in between the back and the front of the eye, you can have the patient look, you know, rotate the eye, and you can get further back on the sclera. So you can actually see, like, you can see schisis, you can see detachments, you can see tears.
With the UBM probe?
Yeah, oh yeah.
So like a tear near the aura? I mean, how, yeah, okay.
Yep. So if you can't get it with the B-scan, or if you're not sure if it's just like
Oh, the
anterior
lens.
vitreous base, or, you know.
Okay.
And most people don't even utilize it for that.
I
It's
didn't
like
even know you
see
could
so
do that.
much with it. So this is a schisis, and this is a good example of how to do that. With a nice little movie.
And how many sort of examples are loaded into the database?
I
mean,
think
between-
about 10 of each.
Oh, okay.
So you can search it by modality too.
Yeah.
Okay, so. So you can see, this is further back on the sclera, so when they scan, there's your angle, your
Yeah.
ciliary body, and then you're gonna have the patient move their eye, and there's further back, and you can actually see the splitting layers of the retina where the
Yeah.
schisis is.
Wow, that's really cool.
So,
So how do you tell the difference between schisis and a detachment?
it's really hard.
Okay.
It's really hard. I mean,
Because that just looks like a detachment, but
Yeah, I
I don't
mean,
know
usually-
anything about this either.
once you see like all the cystic kind of components in there, see, you can actually see it split. That's more indicative of a schisis. Also, if it's in both eyes.
And the retina doctors are the ones that
Yeah.
have that
Yeah.
height to do it.
Yeah, 'cause sometimes, you know, they'll send you an OCT and they'll be like, can you get way out here? I wanna see if this is a ski system. And you're like, the patient can't, like,
Not with
you can't have the patient look that far, so that's where the UBM will, and it's not often that these happen, but, you know, I used to do B scans, and I would just say, all right, I'm gonna do a UBM now, because I need to know for sure. You know, it just kind of becomes second nature when you've been doing it so long. But that just shows like how far back you can actually get. Now, setting up the UBM probe, this is a clear scan bag. So this is a disposable, one-time use little kind of, like a cover for the UBM. So you're gonna fill it on this side, on the green side, not the cardboard side. And the probe is gonna insert into this. So, usually I'll do this with a gloved finger. But you wanna kind of open this. This is the part that's gonna touch the patient's eye, so you wanna keep that really clean. And then, I'm just gonna use some of this, if that's okay.
Yeah, that's what I.
Is that fine? Okay, so when I fill these, I usually have like a trash can right under me because I might spill some water. You don't have to get, I mean. I was just gonna
We
pour it
don't need
all
to
over
make
your
a mess.
carpet. All right, so, usually you wanna use like a distilled water for these, only because you don't want the salt to kind of crystallize around the transducer. You're gonna fill this up. Sometimes with these little bottles, they'll create like a lot of air bubbles, and you'll see that on the scan too as artifact. But it's good to know what you're looking at, just in case it happens to you, so you can see all the bubbles in there. So I filled it like almost to the top, to the rim of the clear scan bag. And then I'm just gonna take this, and I like to have it around my neck again so I don't drop it, because I'm really clumsy. And I'm just gonna kind of insert that in. And I've sprung a leak.
Oh, yeah.
So it's good for you to see. I did this in the OR once and everyone was laughing. But that's the gist of kind of, and you can see this big air bubble there. So I'm gonna just kind of squeeze a little bit, and that kind of took that air bubble out. So squeeze with 2 fingers here. And you can see how there's like a little bit of wrinkles like around that. That's pretty much how you want it to be. And then when you,
Does that cup sort of lock in place on the probe?
it
Or
just
just
fits
kind of
right to the
fits right?
collar. So you don't wanna push it too far, or else you'll just break right through that bag. And you kind of feel where it stops there. And so, you can see the transducer is oscillating. Now, if I got pushed too hard, or if I didn't have enough water, I could feel that on my hand. Okay, so the key is have enough water in there, not too much, not too little, and you wanna be right in the focal zone. Actually, let me try this one out. Cause there's a big hole in that. And I don't wanna waste these, but I wanna show you guys. Does anyone wanna try to set it up? Like, just to practice or no? No?
Do you have to have that thing on the UBM?
So the only other option is to use this.
Which is like the shell,
Yeah.
the handset shell?
Now,
Okay.
when you're first learning, I advise not to use that.
Okay.
Because
It's just more difficult?
not only more difficult, but if you go too far into here, you're gonna abrade the cornea.
Oh, okay. Yeah, right.
So,
I wanna practice
yeah.
setting that up.
I was trained on this just because my mentor was old school, and she was
Okay.
like, you're going that way. So, which I appreciate, because I like to learn the hard way sometimes, but, all right.
So we're gonna put that clear plastic shell on.
And these little packages,
So these are called just disposable.
these are clear scan
photos?
bags, yeah.
Clear scan bags,
Yeah.
okay.
And you'll see there's an expiration date on the bottom, so,
You'll have to get some more, because we don't have
Yeah.
that many, do we?
yeah, there's 10 in a box.
Gotcha.
So, and
Okay.
hopefully we can only just use one.
Yeah,
Even if people wanna practice, we can use the same one.
okay.
So there's one corner that peels open, because I've spent like hours trying to,
Question, please.
yes.
Between this one, the clear scan
Yeah.
and that one,
Yeah.
which one's more accurate?
Accurate?
Yeah.
So it just depends on what you're looking for. With the cup, you can't really get back on the sclera, like for that schisis one, because it's fixed. It's almost like the A-scan shell where you're just looking straight ahead. So if you just wanted to get like an anterior view, like what we saw with the lens straight through, that cup is fine.
Okay.
But if you really wanna kind of customize it and look at different areas, the bag is best. All right. Okay. So you're gonna turn that over.
So this way.
Yep.
Which is the opposite of what you think it would be.
Yep.
And then just fill
Cause
this
it
up.
creates a seal, yeah. And sometimes like you can jiggle it a little and it will fall open. Sometimes if it really won't, I'll take a gloved hand and just kind of open it a little, cause that's not gonna touch the eye.
Okay, pretend my hand's gloved.
Yeah, absolutely.
Break
Really
it.
sticky sometimes.
I'm just wondering how
Yeah, it's-
delicate it is.
Yeah, yeah.
Mhm. Really doesn't, I'm not open.
Look at that, there's like a. There you go.
Alright, so we
Say
need more.
that 'cause they're recording, but. It's caught on.
Yes, they did. Alright, here we are.
Yep.
Now what?
And then you just place that in, and you'll see where it
Oh.
stops, right at that collar.
Oh, just
Yep.
all the way in.
Yep, that's okay if water leaks out, that's perfectly
And
fine.
then do I
And then just,
twist it?
nope, just not jam it in, but yeah,
Jam it
there you
in.
go. And then you'll see, turn it sideways. So see how there's like, it's really full,
Mhm.
and you have that big bubble? So now take 2 fingers and just kind of pinch.
No,
You can use it.
okay,
You can
hand
use
it
that's fine.
out. This is exactly how you do this.
Here.
I wanna try it again. So the trash can was purple here.
Yeah.
This is a lot of solutions, and distilled water works best. And remind me again why, with the salt or
The salt,
something?
yeah, because it will crystallize around the transducer.
So I filled it way too much then.
Not on the UVM transducer.
But you can take it off,
because
it's just hard when you
as
handle
turn
it.
off,
Right.
it moves it.
Okay, so I
Okay, so
have a
then-
giant bubble, so I'm just gonna squeeze it.
Yeah, so you want to do like,
The transducer
To not-
itself,
Did she
Like
change
this.
the transducer head?
I don't
it's
wanna
just
do
a
it 'cause I want
separate
you to do
one,
it.
so.
Oh, kind
Yeah,
of
so
let
see
it
how it
burn.
bursts?
That's all you
Yeah.
need, so I need a little bit more of that.
yeah,
'cause there's
so you just
another-
want to like, take it from, I usually do it right on the top.
So they're completely
Like
different
this.
modalities.
Oh, gotcha.
Yeah,
Okay.
so the
But if you hold that up now,
are a different
see how it just-
velocity
yeah.
in each.
Good,
Alright,
yep,
so is that, do we need more solution
no,
in here?
that should be fine.
Can I ask
Okay.
a question?
Perfect.
Yeah.
How do you place that on a patient?
Okay, so for Paracane, and then you can put a little genteel on the bag. And so it will, you know, a lot of people
Genteel
with
gel
dry eye,
on the
if you
bag.
just put the bag right on the eye, it's just kind of irritating. So genteel,
It's
but
like
it
a
also
really
helps
soft
you move the
contact
probe on
lens.
the eye to get a good image,
Doesn't hurt. Okay.
okay? And then with the water, how you know you have a good fill, like if you put that up just right on your hand, like you're gonna
Mhm.
scan your hand. So see how you want it, so press more, see how it goes up? So the more you press, the closer you're gonna get to the cornea. If you just lightly press, just like this, you're gonna be in the middle of the focal zone. Okay, that's what you want. If you're not pressing at all, your image is gonna go way off the screen on the bottom. That's also the key if you have too much water or too little water. Too little water, you're gonna be too close to the cornea, which is gonna go up towards the top of the screen. And too much water, you're gonna be way off the screen down towards the bottom. So it's all about getting in the focal zone.
Question.
Yes.
While Ellie is doing it, can you show us like a scan?
Yeah.
We don't have any schematics that we can scan here.
I know. I mean, I can scan my eye, but.
Yeah,
I
you
can
can
be
scan
a
mine
patient.
out.
Yeah.
Yeah, that'd be
I don't
cool.
mind.
I mean, if you don't, I don't know if you have
So let's-
Paracane, but
Yeah, we
Yeah.
have everything.
yeah,
Yeah, I'll
So I
know that just.
Do you want to use
I'm
car
gonna
as
go
a
wash my
patient?
hands.
Okay.
We'll start a new one.
Oh, Alex.
Do you need anything other
We can
than
reuse
prayer?
it for the
Absolutely
next
not.
Yes,
group,
yes,
so that we don't open up another one.
exactly.
Hey Ellie, we have a patient right here.
Sweet, let's do
We don't
this.
have contacts in, right?
No.
All right, so he's gonna get prepared, Kane.
Okay, do you want me to?
And, yeah, I'm gonna go wash my hands. Do you wanna go wash your hands too? We'll just do some hand washing, cause we don't have a sink here.
Sure.
And, then maybe then we can glove up and everything.